Hello, my friends. It is Dr. Atkinson here, and today we are diving into another key electrolyte, chloride. Now, I know chloride does not get the same attention as sodium or potassium, but it is absolutely essential for keeping our bodies running smoothly. If you ignore it, trust me, it will make itself known. What is chloride, and why do we care? Chloride is the major negatively charged particle, or anion, in our extracellular fluid. It works hand in hand with sodium to maintain osmotic pressure, water balance, and the integrity of cells. It helps regulate acid-base balance, is a key part of stomach acid for digestion, and even participates in the oxygen-carbon dioxide exchange in red blood cells, something we call the chloride shift. The normal range for chloride in the blood is 98 to 106 milliequivalents per liter. Levels inside the cell are much lower, about 4 milliequivalents per liter. Chloride levels tend to move in the same direction as sodium and opposite to bicarbonate. So if sodium drops, chloride often drops with it. If bicarbonate rises, chloride tends to go down, and vice versa. Part 1, hypochloremia. When chloride is too low. Definition. Hypochloremia means a serum chloride level below 98 milliequivalents per liter. Causes. The most common causes are losses from the gastrointestinal tract, vomiting, gastric suction, gastric surgery, diarrhea, or drainage from GI tubes. Other causes include low sodium intake or loss of sodium, IV fluids without chloride, certain diuretics, loop osmotic or thiazide, overuse of bicarbonate, massive blood transfusions, diabetic ketoacidosis, Addison disease, SIADH, burns, fever, excessive sweating, overuse of laxatives, rapid removal of acidic fluid. Pathophysiology. When chloride is lost, sodium and potassium often go with it. To compensate, the kidneys may hold on to sodium and bicarbonate. That bicarbonate buildup can cause metabolic alkalosis. If hypokalemia is also present, the risk for dangerous heart rhythms increases. Signs and symptoms. Hypochloremia can look a lot like hyponatremia or hypokalemia. You might see agitation, irritability, and tremors, hyperactive reflexes, muscle twitching, tetany, and cramps, weakness and slow, shallow breathing, seizures or coma in severe cases. Remember, if sodium is low, water may shift and cause swelling in brain cells, leading to more severe neurological symptoms. Lab findings: low serum chloride, low serum sodium, high pH, high bicarbonate, low potassium, low urine chloride. Management. The main goal is to treat the cause and replace chloride. This might mean giving normal saline or half-normal saline, adjusting or stopping certain diuretics. In some cases, using ammonium chloride to correct alkalosis, but not in patients with liver or kidney disease. Nursing care. Monitor intake and output. Watch ABG results and electrolyte trends. Check muscle strength and neurological status. Teach about high chloride foods: tomato juice, bananas, dates, eggs, cheese, milk, salty broth, canned vegetables, processed meats. Warn patients who lose chloride through excess urination or sweat to avoid drinking only pure water with no electrolytes. Part 2. Hyperchloremia. When chloride is too high. Definition. Hyperchloremia means a serum chloride level above 106 milliequivalents per liter. Causes. Many cases are iatrogenic, caused by us in the hospital, usually from giving too much sodium chloride IV fluid. Other causes include dehydration, head injury, hypernatremia, kidney injury, corticosteroid use, severe diarrhea with loss of bicarbonate, metabolic acidosis, respiratory alkalosis, certain drugs, acetazolamide, ammonium chloride, sodium polystyrene sulfonate, hyperparathyroidism, overdose of salicylates. Pathophysiology. Excess chloride often comes with a loss of bicarbonate. The result? Hyperchloremic metabolic acidosis. When bicarbonate goes down, chloride moves up to balance the electrical charges. This shift changes the blood's pH and can lead to widespread effects on organ function. Signs and symptoms. These often look like metabolic acidosis or hypernatremia, fluid retention and swelling, fast, deep breathing, weakness and lethargy, trouble thinking clearly, high blood pressure, in severe cases, decreased cardiac output, arrhythmias, or coma. Lab findings: high serum chloride, high sodium and potassium, low pH, low bicarbonate, normal anion gap, high urinary chloride. Management. We treat the underlying cause and restore balance. This might include switching to hypotonic IV fluids, using lactated ringers to increase bicarbonate, giving IV sodium bicarbonate, using diuretics to eliminate excess chloride, restricting sodium, chloride, and fluids as needed. Nursing care. Monitor vital signs, ABGs, electrolytes, and INO. Watch for changes in breathing, mental status, and heart rhythm. Teach about diet changes and the importance of maintaining hydration. Key points to remember. 1. Chloride moves with sodium and opposite to bicarbonate. 2. Low chloride often means low sodium and metabolic alkalosis. 3. High chloride often means low bicarbonate and metabolic acidosis. 4. Always address the underlying cause, replacing or removing chloride as needed. 5. Nursing care is about monitoring, education, and prevention. That wraps up our lecture on chloride. It may be the quieter sibling of sodium and potassium, but it is no less important. Balance matters, and chloride is one of the electrolytes that keeps everything else in line.